Hello, everybody. Good afternoon, and welcome to today's expert panel on cardiovascular healthcare disparities and health equity part two. This topic is so critical to discuss, and we are thrilled to be hosting a second session about it. My name is Alina, and Leigh and I are going to be the moderators for this event. Before we get started, I'd just like to briefly introduce us and the organization that is hosting this event. So we're here today representing Guardians of the Heart. It's a student-led nonprofit whose mission is to empower young people with the knowledge, tools, and resources to take control of their heart health from an early age. And today's conversation will center around cardiovascular disease and social determinants of health, with a special focus on how community, educational, and societal factors contribute to these disparities and kind of what we can do together to address this. We're incredibly fortunate today to have such an outstanding group of experts with us who will be sharing their knowledge on this crucial topic. And now I'm going to pass it on to Leah to introduce our panelists here with us.
Hi, so first, Assemblyman Josh Jensen currently serves as the ranking minority member of the Assembly Committee on Health, as well as a member of the committees on banks, corporations, authorities, and commissions, insurance, and libraries and education technology. He believes in serving as a common sense voice for his constituents and always putting their interests first. And he works to make New York State a more affordable place for the families that call it home. Prior to being elected to the Assembly, he served as the Director of Communications at one of upstate New York's largest nursing homes and worked as a client strategy and relations supervisor for a Rochester area public relations agency. Second, Dr. Sandra Albrecht is an assistant professor of epidemiology at the Columbia University Mailman School of Public Health. She is a social and nutritional epidemiologist whose research focuses on understanding the social and environmental risk factors that contribute to the high burden of nutrition-related diseases in immigrant and Hispanic/Latino populations. Her most recent work uses community-engaged and mixed method approaches to understand the barriers and facilitators of healthy eating for populations at risk for type 2 diabetes and cardiometabolic complications. Third, Dr. Patrick Thomas is a board-certified cardiologist and assistant clinical professor of medicine at Columbia University, where he helps train future cardiologists. He previously served as chief of cardiology at New York Presbyterian/Hudson Valley Hospital and chaired its medical executive committee. An active clinical researcher for over 2 decades, Dr. Thomas has focused on developing therapies to prevent and treat cardiovascular diseases while advocating for equitable access to care for underserved populations. He is also the American Heart Association Westchester and Fairfield counties board president, where he works to address disparities in heart health across communities. Next, Dr. Mary Andrews is an IDEA Inclusion, Diversity, Equity, and Access Fellow in Health Disparities in Critical Health as the School of Communication and Journalism and ALDA Center for Communicating Science. She investigates how intersecting social identities and experiences in daily life influence health and well-being across populations to influence public health. In addition to deepening our understanding of how these factors influence each other and impact population, Dr. Andrews seeks to apply her research to real-world health communication practices and public outreach initiatives. Finally, Dr. Monica Stafford is the Chief of General Internal Medicine and founder and co-director of the Cornell Center for Health Equity. She is a health equity researcher who has conducted 4 large trials with African American patient partners to improve heart and brain health. She has published her work in over 600 publications in the peer-reviewed literature, and she is an award-winning mentor of younger investigators, especially minority women scientists.
Thank you again for joining us today, panelists. So Leigh and I will be guiding this discussion using some pre-prepared questions, and we'll also end with a Q&A session, so everyone feel free to type in the box if you have any questions along the way. Okay, I guess we can get started with kind of a big picture question. Really just what does your experience with health equity look like, and how do you work in your field to combat disparities? So Assemblymember Jensen, would you like to start us off?
Yeah, would love to, and I'm sufficiently intimidated by my fellow panelists. So it's nice to start first before they make me look silly. No, I just want to thank you guys for doing this. Certainly my experience with health equity is looking at it through the New York State budget and our laws and policies of the state of New York. And I think one of the biggest things that New York can play a role when we look to address health equity is through our state's Medicaid program. Around 45% of all New Yorkers are currently enrolled in Medicaid. It accounts for just over $110 billion of our New York State budget, which is a substantial amount. And the Medicaid program is the payer source for underserved communities across New York. People living with in poverty, complex medical needs. And so when we talk about how as a state can we combat disparities between different ethnic groups, between male and females, between regions of the state, it's ensuring that we have a Medicaid system in New York that is not just efficient, but is also effective and is looking at the social determinants of health to ensure that all New Yorkers, whether they're on Medicaid or not, have access to the care they need when they need it, and hopefully before they need it, so that way we can nip some certain things in the bud. And that's where, when we look at our Medicaid program, because it is dual funded by the federal government and state government, is a lot of times the state has to apply for waivers to look at new and innovative ways to utilize those Medicaid dollars. And it's about finding programs and policies and reimbursements for a way that's going to have the best impact and hopefully ensure that we can lessen disparities while increasing care across the board. So, that's been my experience. And I've been lucky that in New York State, oftentimes, not just as a leader in the healthcare field when it comes to policy, that we do have broad bipartisan cooperation on a lot of these things, where at the federal government, that's not necessarily always the case.
Thank you for sharing, Assemblymember Jensen. Yeah, I really like your point about having access before you need it. I think it really captures kind of the rising emphasis on prevention over treatment and care. And Dr. Albrecht, we would love to hear your thoughts on this as well.
Sure. So, yeah, I've been working in the sort of health equity space for a number of years now. I have both professional and personal interest. My mom's side of the family comes from an immigrant Spanish-speaking family, grew up in Queens, New York. So some of it came from this personal interest and seeing just from my own eyes growing up. But then, moving into the professional side of things, I really have been wanting to understand what are the barriers to management of chronic diseases in different populations. So, and when I mean management of chronic disease, I mean management of diabetes, of hypertension, high blood pressure, high cholesterol, and these sorts of things. We see lots of disparities in just the managing of, we see disparities in the prevention and the development of diseases, but pretty terrible disparities in managing these conditions too. And in general, a lot of this has to do with access to health care, lack of health insurance, and so forth. But in a lot of the work that I do, we actually see these huge disparities, even for people that have access to care. So they have health insurance, they have a regular doctor, and even still, we see these disparities. So what I'm interested in is understanding is why. If you have a regular doctor, you have health insurance, and this includes private insurance too, in addition to Medicaid, we still see really, really large disparities in control of diabetes, control of hypertension. So I really try to come at it, trying to support patients in terms of factors outside the healthcare system. So in other words, what can they do to improve their diet, especially nutrition? I'm actually trained as a nutritional epidemiologist. What can we do to help support them as they change their diet to be healthier, and to engage in more physical activity? Because it's not really just about education. A lot of the patients actually know that they need to eat healthier. They know what they need to do, but it's just really hard. And there's a lot of barriers, in the society and the neighborhoods that they live and just their lives in general. So we're trying to understand what those barriers are and try to inform interventions to address the barriers so that they can get better over time.
Thank you for that. What about you, Dr. Thomas?
First, I would just like to say that I'm completely stunned by the depth and the breadth of expertise on the panel that you've assembled today. I am certainly not an expert in health equity or healthcare disparities. I've just been in the trenches cardiologist for more than 2 decades. But I've taken care of everybody from Wall Street bankers to dairy farmers and day laborers and everything in between. The sad fact is that heart attacks and strokes hit every race, every gender, every economic strata. Health equity for me means very simply making sure that the same level of preventative services and the same level of post-event care are available for everybody, irrespective of where you fall in that list of professions or list of races, list of genders. So in my role in teaching down at the medical center at Columbia, Washington Heights is a very large immigrant population that's generally quite poor and very different than just literally a few blocks down the road. And so a lot of the cardiologists that are in training have not been exposed to patients in that particular demographic. And so my experience in treating everybody across the board has led me to come up with some strategies to help them and help educate them in the clinic as they're taking care of people. Additionally, through the American Heart Association, I'm leading an effort to try to improve cardiovascular disparities in rural communities in particular. I don't think most people realize, although the Assemblymen and others on this panel certainly do, but that life expectancy is quite shorter in rural communities than it is in either suburban or urban communities, and outcomes of heart attacks and strokes are significantly worse. And there's lots of reasons behind that we can perhaps get into as we go through. But we're working on trying to address that and get to some of the root causes, and more importantly, come up with some solutions to fix that. So again, for me, health equity is simple. It's everybody gets the same level of prevention and the same level of post-event care.
Thank you, Dr. Thomas. What about you, Dr. Andrews?
Well, my interest in health equity and doing research in health equity started being just like in my family and being a human and noticing things. I'm a mixed race, and on my Black side of my family, both of my grandparents died of tobacco-related diseases, while my white side did not, even though both smoked. There was different like rates of like when they quit or like what they had access to or how it's like tied to their identity, what was promoted to them. But it made me realize there's like something inherently like non-biological in the world that can contribute to health. So I got really focused on behaviors that lead to diseases like cardiovascular disease. And so a lot of my work focuses on tobacco use, but other preventative behaviors as well, where I see how things in people's environments, usually messages like advertising they're exposed to or interactions they have with people, like whether they feel like they're discriminated against or in some other way as like a way to cope with the stress in life, if that leads them to engage in coping mechanisms to deal with that stress, that can have long-term health consequences. And on the other side, I try to design communication interventions that help motivate people to then engage in behaviors that will have a downstream effect on health, whether that's eating better, exercising, going to preventative services if they're available. I think as Dr. Albert said, it's not just education, there's like another level of getting people to actually engage in the behaviors. So most of my research is showing what's bad in the world and how we can try to motivate people or make systems better so people can better engage in preventative behaviors.
Thank you for sharing. And let's move to Dr. Safford.
Yeah, thank you very much. So, I completely agree with all the things that folks said. I just want to comment on one thing that Josh Jensen mentioned. A lot of us think Medicaid is for poor people. There's a gigantic number of people who are quite well off who are on Medicaid. And I think that it's a really, really important thing as the Trump administration tries to disassemble this country for us to bear in mind. It is definitely a war on poor people, but there are a lot of people with plenty of wealth who have very complicated medical conditions, disabilities, who benefit enormously from Medicaid. So it really goes all the way across the socioeconomic spectrum. And it's something that's really very much underappreciated. And you all being in the high school where you're at, You probably don't have personal connections with people who rely on Medicaid. But it's really, really important to advocate very strongly to keep these benefits. It would be devastating if we did not. In fact, if you look at observational studies of states that expanded Medicaid under the Affordable Care Act, there's actually more deaths. So it is directly related to life expectancy and mortality. I really want to stress the behavioral aspect. The American Heart Association had this absolutely brilliant concept called Life's Essential 8, which built on an earlier version called Life's Simple 7. I love the fact that it's getting simpler in its messaging, because I think sometimes in medicine we tend to overcomplicate things. I don't know, Patrick, if you agree with that. You're nodding. But it is pretty simple. Here are the 8 things you need to do. And what we're finding is that it goes way beyond cardiovascular disease. If you do these 8 simple things, you also reduce your risk of cancer. So it's sort of this guiding light with what do we need to do? So we know what we need to do. I think Sandra also said that. But how do we help people to do it? Changing behavior is really, really tough. So, if you know that you have to study for an exam and you have a million friends on social media, and before you know it, it's 10 o'clock at night and you haven't started studying for your exam, how do you wean yourself off social media? It's a really, really tough thing to do. So one of the things that I have been studying for the past 10 years, which I think holds a tremendous amount of promise, especially in marginalized communities, is a concept called peer coaching. So you take people from the community, and Dr. Perez probably knows a little bit about this. There are some folks in a lot of Latino communities called promotora de salud. They are promoters of health, is the translation for it. And they are usually women who really care a lot about their communities. And you can engage them, and with a little bit of training, they can help their fellow community members to succeed at these life's essential 8 in the context of their communities with all the social determinants that they have to confront. So this is probably one of the biggest gaps that we have in the American healthcare system, is people who are behavioral interventionists who can actually help us to change our behaviors. We are missing that right now. There aren't enough psychologists to deal with our mental health conditions, let alone help us to change our behaviors. So one of the things that I'm a very big proponent of is to figure out how we can integrate peer coaching as a reimbursable expense in the healthcare system. I hope, Josh, you're listening, because these folks are absolutely vital, and it also addresses a very important part of the gaps that we have with community capacity building. So we have huge disparities in unemployment. And a lot of these folks are in their middle years. They have another job. This gets them just a little bit of extra money and can help their fellow community members. And we have shown, and there's several groups around the country who have been conducting studies of peer coaching to improve cardiovascular health as defined by either Life Simple 7 or Life's Essential 8. And it's really interesting what kind of dramatic results you can have. So peer coaching for the win.
Thank you so much for sharing all of that. And I think going back to what a lot of you talked about regarding education, I think I want to shift the focus a bit to education and its impact on cardiovascular health. So kind of from your perspective, what role do you think schools and educational institutions can play in preventing heart disease early on, especially in more underserved communities where resources may be more limited compared to others? So why don't we go in the reverse order for this one? Dr. Safford, would you like to start us off?
Yeah. I mean, this is a huge opportunity. And I think that one of the problems that we have sort of boxed ourselves into with our approach to education is the life of the teacher is pretty unsatisfying. They're having to teach to the test. They don't necessarily have a lot of leeway to adapt what they're teaching to the students in their schools. And there's just a tremendous amount of emphasis on test results and test scores. And what we really need to be doing is emphasizing in especially the very early years, the incredible importance of physical activity and healthy eating. It's amazing how many public schools don't have full service kitchens. All they have are microwaves and to heat up the pizza. We need to do a much better job of working with nutrition experts at schools so that we serve healthy foods and teach kids by doing, not just, in a classroom with a whiteboard behind us, but actually at the lunch counter. What are the options that you can choose that are healthier? We need to do a much better job of overcoming some of the lobbies. I think this is Josh's world. But we really shouldn't be eating very much red meat. It's good for our bodies and it's good for the planet to greatly reduce red meat consumption. Unfortunately, the beef lobby in this country is very, very strong. So our messaging around that, even the American Heart Association doesn't have liberty to really say what the evidence shows. What we all ought to be doing is a whole food plant-based diet as much as possible. It would be much better for our own health and it would be much better for the planetary health. We need to teach kids this from the earliest stages. And you can have very delicious food that is not meat-based. So it's an enormous opportunity, but it really has some major barriers associated with it because of costs. A lot of schools make money from their the put the nickel in and out comes, a candy bar. That's how they fund some of their programs. So, it requires a lot of commitment and a lot of creativity to make it a fun learning experience, but then to put into action what we're teaching.
Yes, I definitely agree. And what about you, Dr. Andrews?
This will reiterate some of that, but I think it is so difficult to explicitly make the connection between certain behaviors or things down to it being something that will protect your heart in the long run, because schools have become a place that everyone's terrified of anything coming off as being politicized, and even something like connecting behavior to health is now political. And also there's so many other features that go into, if you're trying to get change the lunch menu, there's always so much pushback, sometimes very real reasons. There's a lot of times different cultural differences of what people eat, and you want people to be excited about the food, or if you don't want to immediately stop what someone's used to, that's going to be a big change. So there's reason for pushback, but it's really difficult on a policy level, I think, in schools to be able, an ideal world, it would be teaching, getting people to kids maybe to even be involved in the cooking and learning that throughout their school years. But I think what actually can happen on a more practical level is just emphasizing the skills you need growing up that you can carry on forever. I think, as Dr. Thomas mentioned, people in all professions have come in with cardiovascular disease, so it's not always tied to socioeconomic status, but I think it's really tied to how you manage stress and behaviors you go in. So maybe getting better social emotional learning from a really young age so people manage stress better, and just getting people excited about different food, and getting people involved in sports, and not just being a habit rather than it being preached as this is going to help your health in the long run, would be my approach with how kind of rocky educational institutes are now.
Yes, thank you for sharing that. And I think the fact that because life's essential 8, there's really 8 huge ways that we can take control of our heart health from an early age that really plays into the idea of starting early and in schools where a majority of students spend their time anyway. And now pass it on to Dr. Thomas.
I actually thought Dr. Albert Perez was next, but I'll take it. I'm happy to take it, whatever works. I do want to state categorically, for the record, the American Heart Association advocates for a mostly, if not entirely, plant-based diet. There's no restriction on the American Heart Association saying that. They've been advocating for that for decades. And I want to pivot a little bit on the idea of schools and the obvious importance of nutrition education and physical activity, but talk about schools as a way to provide healthcare resources in underserved communities. So a lot of times people have difficulty getting to a doctor, getting to a dentist, getting to a mental health professional. And we'll be talking about technology in a little bit, but one rather innovative way that actually is fairly common throughout Europe is to have a health clinic, a dental clinic, a mental health clinic right within a school. So for these underserved populations that don't necessarily have access to those services, having that available within a school, not just for the students, by the way, but for their parents, could be an absolute game changer in terms of being able to even the score and eliminate some of these healthcare disparities that we're here to talk about today. So I just wanted to throw that in because it's not something we talk a lot about. And again, I understand the pressures on schools in terms of budgets, in terms of teachers' time, in terms of space to fit the clinic. There's not enough space in most schools. So I understand that there are huge impediments potentially to some solution like this. But it's been done in a lot of different places, most of them outside of the United States. But interestingly, I've run into a few in upstate New York. So I think it's something that's worth consideration, something worth talking about. And I'll leave it at that. Thank you.
Thank you for sharing, Dr. Thomas. And now, Dr. Albert, what would you like to?
Yes. So, it's funny because, of course, a lot of the things that I was going to mention are, have been raised in many ways. And also, I'm coming from the nutrition side of things. I'm always a proponent of, nutrition education especially at a young age. Interestingly, because I'm at Columbia, we also have Teachers College. So we actually work a lot with the faculty that work in the schools. And when we try to implement some nutrition education, we're doing a few pilot programs. And some of the things that we're learning is that, on the one hand, it has to be fun, right? So it can't just be about, this is a healthy food, this is a bad food, that sort of thing too. So also our approach to teaching about nutrition really needs to be more about, just understanding the variety of foods that are out there, that, the types of healthy foods that we have don't always need to not taste that great, that sort of thing. I know with my kids, sometimes, they'll taste something, they might not like it, and they're like, that must be a healthy food. And I was like, oh my God, that is not the approach that we're trying to, get at here, because there's a lot of healthy food out there that can taste really good if prepared well. And so, coming at nutrition education in a way that's actually fun and, and specific to the developmental stage of the children that we're trying to work with, I think is really important. In an ideal world, and obviously we're living with constraints, incorporating cooking so that kids also learn how to cook, stuff that they can also sort of share with their families, share with their parents, just finding a love for cooking again, just because that's something generations ago, and that's the way we largely ate, and that's no longer the case now, especially in the United States. And so bringing aspects of cooking, that's also hard with limited resources. But as an example, there are some schools where there's parent-teacher associations that are trying to do sort of even Zoom cooking lessons for families that are in the school, in the evening. So things like that, just kind of different ways to bring that in. And then also, similar to what Dr. Thomas brought in terms of resources. So healthcare resources is one thing. The other piece about it too is just resources to, nutrition supports that are out there. So for example, SNAP benefits, SNAP, WIC, there are these federal programs, which, we'll see if they're going to be around for much longer or not, but, for now they're still there. And these are also resources that help families afford food. And a lot of families do not enroll. They're either not aware of it. The paperwork is really cumbersome. There's a whole host of reasons why people don't enroll in these federal programs that are available to help them eat more healthy and to help address food insecurity. And so again, schools or working with the social workers also could be another way to help link these families to the existing resources that we have.
Thank you for sharing, Dr. Albrecht. And what are your thoughts, Assemblymember Jensen?
Yeah, well, I first of all want to say that I think it is very interesting because everything my four fellow panelists have said is in some way, shape, or form, either directly or indirectly, part of the budget negotiations on the state budget that we're currently going through. If it's not in budget negotiations, then it's something that has come before the health committee or the insurance committee. So it is interesting that we've identified as a state a lot of these issues and are trying to fine tune the way to go for it. But I think when we're talking about education, um, I'm of the personal belief that I think our education system now doesn't do enough to help prepare young people for the world in which they're going to encounter, whether that's media literacy, digital literacy, and in this context, health literacy. That's something that, we talk about the importance of eating healthy, which is obviously critically important. I'm not going to argue with anybody with so many doctors in the panel in the chat. But how many young people know that dental health is critically important to heart health? And so you may go get your checkup twice a year, but are you going to get your teeth cleaned? Are you going to visit a dentist? So I think that's where if we can increase health literacy and ensure that young people understand the choices they make and the impact that those choices have, not just on their immediate health, but their long-term health, I think that's a direction we need to consider moving. I think the other thing schools can do more is encourage career and technical education. One of the reasons why we do have health disparities and unequal access to health is that we have an unequal distribution of providers. And so, if we're able to encourage young people to pursue career and technical education, we may get more dental hygienists, we may get more nurses. And especially if they're coming from underserved communities, there may be incentives, whether they're tax rebates, tuition assistance, to get that education and then go back and serve in the communities that they call home. This week or this past week in Albany, I met with the dean of Stony Brook's dental school. And right now, they're offering free tuition for individuals in underserved communities to come and go to dental school if they go back and serve in a community either that they've come from or that is similar. And that's something where increasing the amount of healthcare providers, keeping them in state, I think will also have a trickle down effect on ensuring greater access to responsible healthcare.
Thank you so much. Now let's talk about heart health against the backdrop of our increasingly digital age. What role do you think technology and telemedicine will play in increasing and/or reducing cardiovascular health care disparities? Let's start in the middle. Dr. Thomas, over to you.
Before I jump into the technology, since we've mentioned Life's Essential 8 multiple times, just for people who don't know what it is, I thought I'd just run through. It takes 2 seconds. So these are the 8 things that if you do these 8 things, or at least attempt to do these 8 things, you will dramatically reduce your risk of heart attack and stroke and cancer and a whole bunch of other problems. So it's eat better, be more active, quit tobacco if you use tobacco, get healthy sleep, manage weight, control cholesterol, manage blood sugar, and manage blood pressure. I hit those very quickly just in the interest of time. And if there's questions about that, I'd be happy to answer them. But that's Life's Essential 8. What role will technology and telemedicine in particular play? Telemedicine has been an absolute game changer since the pandemic for delivering care. Now, I cannot listen to somebody's heart through a Zoom chat, although I'm guessing the technology will come along at some point where I can. So there are certain things you can't do via telemedicine, but there's a whole lot you can do. And I bet most people, the panelists certainly know this, but I bet most people watching this webinar did not know that telemedicine really wasn't reimbursed prior to the pandemic. Dr. Safford had mentioned, getting reimbursed for peer coaching. We're about to see the end of reimbursement for telemedicine. So telemedicine was a temporary reimbursement during the pandemic, and it's been extended a few times. The most recent extension has carried us now to September 2025. And I'm very, very concerned that if the reimbursement for telemedicine goes away, that the healthcare disparities and the people who need care the most um, uh, are going to suffer because of it. Technology really does, enable us to do so much more, and not just in terms of telemedicine. There are other technological advances that can work on access for underserved areas. So, for example, in upstate New York, a lot of times roads are impassable because of snow, and that isn't plowed or is plowed incompletely. And so using drones to deliver medications or using drones to deliver AEDs in the setting of a cardiac arrest is one example of technology that's it's not theoretical, it's already being used in that way. So I am very excited, very anticipatory in terms of seeing what comes next with technology. Everybody talks about AI at the moment, artificial intelligence. So far, it has not really worked its way into medicine so much, but we're hoping that it will and can allow us to deliver care more quickly and more equitably in the future. Thank you.
Thank you so much for sharing. Dr. Andrews, what are your thoughts on this?
I'm going to speak more to just technology rather than telemedicine, as I'm a communication scholar. A lot of interventions I focus on are like how to deliver messages in a way that will get people to engage in whatever kind of behavior you're focused on. Most of the time, it's usually what I focus on is preventing people from using tobacco or quitting tobacco at the end. And I think technology, while also a vice and adds a lot of stressors and more issues in our day-to-day life, it can be leveraged to reach so many more people in one sense, from a thinking from a equity sense, or just being more inclusive, more people. Being on different social media platforms has brought people to get different people with various interests or cultural backgrounds together in a way that hasn't before. And that can also be leveraged when trying to motivate people to engage in healthier behaviors, whether that's having a community to lean on as a way to handle different stressors in the day-to-day life, or just learning, being able to work with people to create messages that are then promoted in those spaces so people see them and are more receptive to them, and they're designed in a more culturally tailored way. And also a thing that's happening a lot and that I've seen in the tech intervention space is having just-in-time interventions, like sending a text or a notification from some kind of app to get people when they're in a state of whether I'll focus on smoking still, because that's what the space I mostly work in. But knowing people, if you know their day-to-day life and know at certain times of day their cravings are higher, then maybe you can send a message that will help them move away from smoking in that moment. Or paying attention to whether they just experienced some kind of negative event, and that can be tracked in some way. But that may also be they're using technology can leverage that to deliver interventions in a way that's individualized to the person, so it gets around having mass messages that don't work for everyone, but tailoring it to that person in how it's delivered, but also when it's delivered. I think prior to a lot of technology, that just wasn't something that could happen. Most communication interventions were on a mass scale and left out a lot of groups, and that's how a lot of health inequities widened if you only focused on the majority group.
Thank you. What about you, Dr. Safford?
So I think technology is sort of a double-edged sword, because although most people in poorer communities do have access to a smartphone, they very rarely have access to the internet. And the data that is often required is a big barrier. They just can't afford it. So I think what Dr. Andrews was talking about is really, really important, that you bear in mind who your audience is. But I'm continually impressed with how innovative people and resourceful people can be when you tell them that they need to do X, Y, and Z, and it requires internet connection. They'll go to the library, they'll go sit outside a coffee shop, they'll go to a school. It's amazing if you can motivate them. So I don't think it's a barrier that's insurmountable. There are a host of apps that can help us to do things like not sit for very long periods of time. Sitting is the new smoking. It's really bad for your health. So using a reminder, I very easily can sit at my desk for 3 or 4 hours at one stretch without moving. That is really bad. So if I have an app that just dings every once in a while and tells me go walk around for 5 minutes every hour, that can actually benefit my health. So there are innumerable apps of that nature that can help monitor your sleep. Are you getting enough sleep? Going back to Life's Essential 8, reminding you before you eat, trying to get in the moment when you need the reminder. I think there are a host of technology solutions that can help people. One of the issues is there are too many. Which one do you choose? So lots and lots of great things happening, but we're not quite at the solidified area where we really have the answer to what happens if people don't have Wi-Fi or they don't have broadband. I've done a lot of work in rural communities where they have no internet access at all. So what do those folks do? And I think Dr. Thomas mentioned that they have a shorter life expectancy. So we really do need to pay attention to what's happening in rural America. But I do think technology has a lot of promise. It just hasn't been worked through quite yet. We're still in fairly early days, but I do think it potentially offers tremendous promise.
Thank you. That was very interesting. Let's move to Assemblymember Jensen.
Yeah, so I'm gonna I want to echo what Dr. Thomas said. Not, I know that he just got echoed as well, or Dr. Safford just echoed him too, so I don't want him to get a big head. But I think the biggest thing that really is going to be the equalizer is the reimbursement rates and mandated coverage for plans. In New York State, Medicaid payers are legislated separately from commercial payers. And so oftentimes we have to pass two separate pieces of legislation to do the same thing, depending on who's paying the bill. And so there has been times where um, health insurers are not mandated to reimburse for certain services, but the state is for Medicaid. And so I think that's one of the things where, and Dr. Safford talked earlier about lobbies, and that's one of the most pressing ones. Now, we don't have too many beef lobbyists coming through the halls of the state capitol, but certainly the health insurers do, and providers do, and the docs do, and that's the thing, is that how do we deliver the greatest return on investment and have the argument that it's going to be cheaper to mandate coverage and reimbursement for telehealth services than it is to pay for the negative outcomes of lack of coverage for those things. And that's going back to the mandating coverage for peer support professionals. That's mandating coverage for an introductory appointment with your doctor. It may just be the checkup to refill a prescription. And so that's one of the things where we're struggling all the time, both in the health committee and in the insurance committee, is on mandating insurance companies and the state to cover certain services. And I think one of the things when we talk about larger technology is that the state doesn't have a mechanism right now to approve new health technologies for treatment for Medicaid payers. I think the last one that was approved was 2019. And so any new technology that's been developed through the pandemic, including something like a pacemaker, it can be used on somebody who's using Excelis Blue Cross Blue Shield as their healthcare provider or health insurance provider. But if you're on Medicaid and it hasn't been approved by the state, you don't get access to it. So I think that's one of the things that, as innovation in this country and worldwide continues to progress, that the state stays up to date on not just in approving the use of that technology and not just relying just on the FDA and the federal government to approve that for everyone as well.
Thank you. Now, Dr. Albrecht.
Yeah, I think, in terms of a lot of his stuff has already been mentioned, but in terms of tech and telemedicine, it's something that should be available to people who want to use it and for whom, they have access to. In terms of whether or not that will, exacerbate disparities or minimize, I think it's complicated. But I do know, again, and a lot of this is from my own work, because as I mentioned at the top, that, we're trying to understand what the barriers are to managing chronic disease, even when people have access to care. And then when we've done studies and asking patients about what some of the challenges are, some of them just talk about not being able to make their doctor's visits because of transportation issues. They have to work, sometimes they have to sit in a waiting room for hours to make their appointments. And it's a day-long affair, even though the appointment might only be 15 minutes or so. And a lot of people can't afford that kind of time. And so if, telemedicine is an option, when, maybe the wait is shorter, or there's a more defined period of when they'll be occupied with their healthcare visit that's more predictable, that would make it easier to help, bring more people into the healthcare system that need it. And so that's why, I was saddened to see this issue regarding telemedicine no longer being reimbursable, because even in the populations that I work with, which tend to be low income and marginalized, for those that do have Wi-Fi and can access it, they have said they love it. And again, because, sometimes they just can't make the appointment. And oftentimes there are also, other hours, sometimes outside, aftercare hours that doctors, make themselves available via telehealth in a way that they might not, if it were just an in-person appointment. So, I'm just really talking about sort of the voice of some of the patients that I work with and the reasons why, telehealth, just having it as an option, it doesn't mean everyone needs to, is not something for everyone. We've also talked to patients who actually don't like the telemedicine option. They want to be able to see the doctor in person and have that interpersonal relationship. So it's not for everyone, but I really do think and wish it would be an option and a reimbursable option for people that need it and want it.
Thank you so much. And speaking of technology, let's turn to the media. I think just for the sake of time, in a few words, what role do you think the media plays in shaping public perception of cardiovascular health disparities? And how can we leverage media to promote more equitable practices? Let's go back to Assemblymember Jensen.
I was really hoping I wasn't going to go first on this one. I think right now the media is not always the best purveyor of information because it is a dollar-driven entity. And they're going to, more often than not, media is going to prioritize what is my assistant, prioritize what is going to help sell ads. And where most people get their information in a media sense is social media, which is not the best place to get factual information. Great for memes, but not great for truth. And so I think this is where, going back to something I said earlier about the education system, is that I think we have to do a better. Brennan, I'm talking about, is that we have to find a mechanism through the distribution of information to ensure that people are getting accurate information and appropriate information. And I don't know what that silver bullet is to do it. But I think that's something where we are beset by conflicting media narratives, is that it's something that I think governments are struggling with, health professionals are struggling with, and people are struggling with in their information intake. So I wish I had a better answer. I wish I didn't go first on this one, but that's what I got. So
Thank you. This is very insightful. Let's move to Dr. Albrecht.
Well, I mean, just in short, media can influence perceptions a lot, whether it's doing it using correct information or misinformation. That's something that the Assemblyman was trying to kind of get at, is that, it's tough to kind of identify what is accurate information these days. I do, I have worked in sort of the information space also, and I did a lot so during COVID, and we actually found sort of local news to be sort of more accurate sources of information. So that certainly definitely is one channel to kind of go with. The other piece too, that at least in terms of the messaging that I think would help if, if sort of purveyors of information would be able to take this up, is just to kind of emphasize the fact that there are disparities, but also to emphasize that the disparities are not necessarily due to or the fault of the people that are sort of under those categories that are, that have that disproportionate burden of disease. So just trying to emphasize the fact that disparities are not really necessarily the fault of the person. There's so many other factors at play that are not always the person's fault, and just kind of emphasizing how there are other factors that come into play that impact how people act, how they behave, and that subsequently impact their disease outcomes in the future.
Thank you. What about you, Dr. Thomas?
So for me, I like to break things down into traditional media and then social media. And frankly, not to offend anybody, but traditional media, print, TV, radio, coverage of health-related information is trash. You get a short blurb about a study with no context, no follow-up, and you'll hear one day that a cheeseburger a day is healthy for your diet. The next day you hear that it's a baked beans and bacon is healthy for your diet, and the next day it's buckwheat and bananas, right? So yeah, you hear all of these different things, and you get 5 seconds or maybe a one paragraph blurb in the newspaper, and you don't really get educated, and in fact, sometimes you get some pretty horrific information. But like I said, it's trash. Whereas some of the trends you see on social media are frankly dangerous, quite dangerous, particularly with regard to diet. Some of the diet things that are trending are so bad that it actually is appalling. For me, a resource that I've just referred my patients to over and over and over again over the decades is it's so simple, it's so easy. It's heart.org. It's easy to remember, right? That's the American Heart Association website. If you click on healthy living, boom, every single thing you want to know about the life's essential aids, whether it's sleeping better, quitting tobacco products, exercise, healthy eating, how to cook a Mediterranean type diet, the only diet ever shown to reduce the risk of heart attack, stroke, and death, right? It's an incredible resource, and where there's so much misinformation out there, there's so much terrible information out there. Heart.org, click on healthy living. It's all scientifically valid information. Science matters. Thank you.
Thank you for this information. Now, Dr. Andrews.
I love this question. This is so super up my alley, what I spend a lot of time thinking about. Also, I wanted to quickly say, Dr. Thomas, I love your alliteration of the foods in the media, the burgers and baked beans to buckwheat and bananas. That was fabulous. But for the sake of time, I want to just quickly highlight one of my colleagues' research. Dr. Nina Freiberger looks a lot about how there's gender disparities in how media, and by media here, I'm talking about I guess advertisements are included, but this also include like TV shows or just like anything like passive in our like mediated environment, but how there's a gendered bias, and when experiencing similar symptoms, usually when it's women, it's usually presented as like anxiety or depression, and there's also a bias then that a lot of men don't connect to those characters doing that, or like seen an ad about a new antidepressant or something. But on the other hand, with cardiovascular disease, it's usually men are way overrepresented, which can be dangerous in just thinking that men are at higher risk, but also, as you know, like heart attacks present differently in women than men, and how symptoms are, and just there's not great media representation of women dealing with cardiovascular disease. So I think I forget what her big plan would be because of this, but I think it is interesting that just like passively, the representation of what we see makes a difference on the type of care we may seek, or like know what symptoms are wrong, to even like, because it's great that there are resources like heart.org or other places we can go to get accurate information, but like passively, unless you're already thinking about heart disease or cardiovascular disease, you're not going to seek out those resources. So I think there needs to be a bigger push of just like more people's stories need to be told, whether that's like in fiction or in TV shows or just in general, so people know that they could be at risk for something and are more likely to get the care they need.
Dr. Andrews is so right about women, whether, again, advertising, TV shows, anything. Women don't think about heart health. They think about, breast cancer. Of course, there's lots of advertisements. There's lots of media coverage of that. They don't think about heart health. And more women each year die of heart attacks than men in this country. And 1/3 of women have completely different symptoms with their heart attack than men do. So I just wanted to amplify that point from Dr. Andrews because it's so important. I think she really hit something good there. Thank you.
Yes, thank you so much for sharing. Lastly, let's go to Dr. Safford.
So this is an area that I care very deeply about because part of the problem with health disparities is most of the information that we have available media online is not designed for people with low health literacy. Low health literacy is 1/3 of Medicare beneficiaries and 1/3 of Medicaid beneficiaries. So it's a gigantic proportion of the population. I was so frustrated with this situation, and the demand for better education is so high in marginalized populations that I actually created an education platform called the Patient Activated Learning System, which is specifically designed for people with low health literacy and for marginalized patients. We have complete information on hypertension. We're trying to work on diabetes. If any of you are wealthy benefactors and want to donate, I'm accepting donations for this platform. We have found that they continue to trust information from the government, which I think is, we're in a new era where that actually is a problem. So I don't know how teachers are going to handle this, but there is misinformation that's being perpetrated by the government right now. But not so much by universities. And I think still the CDC, although even the CDC is being sort of turned into a puppet, but people do trust university sources and organizations like the Heart Association. So teaching, especially young people, what are reliable sources of media information, driving people to those kinds of media platforms, I think that's really essential. I am going to have to go in 2 minutes, though.
Yes, thank you so much for sharing. And just looking at the time, I think we have 2 minutes left. I do see one question in the Q&A, so I'm just gonna get to it really quickly. I guess if there's is there any particularly unique or helpful approach that you guys have encountered that addresses a cultural gap in cardiovascular healthcare? And I guess I would just add on to that, and maybe how do you see it being successful in a way where other interventions maybe weren't as successful? So if any of you would just like to jump in really quickly on that.
Peer coaching. That's what peer coaching is all about. It's culturally concordant care. It's people from your culture who have been taught, how do you translate life's essential 8 into my culture? And they are the ones who are teaching fellow community members how to stick to those goals within the context of their lives. So that's why I'm such a big proponent.
Thank you. Would anyone else like to add anything on?
Just a quick word, the American Heart Association's approach to improving community health across the board is really to partner with local organizations that work in those communities. So it's one thing for me to advocate for something, but I think it works better if I work with a local food bank or a local health clinic in that area and use the resources there and help hopefully provide more resources to that area rather than just going in by myself.
Great, thank you so much. And I think that concludes everything today. We've covered a lot of topics, and thank you to all of our panelists for your invaluable contributions and helpful information from a variety of perspectives. And thank you for everyone for tuning in. We hope this conversation has provided everyone with kind of some practical takeaways for addressing disparities in heart health and advancing health equity in your own communities. And as we've heard today, the work is really far from over, but kind of working together and committing to this movement and initiative, we can make a meaningful difference. So to learn more about Guardians of the Heart and our upcoming initiatives, please visit our website at www.guardiansoftheheart.net. Thank you again, and we look forward to continuing this important work together. Have a great evening, everyone.